Welcome to Drawn, the podcast that draws you in with stories of hope, healing, and even a little hustle while battling anxiety and depression. Think you have to wait until you've conquered your mental illness to start living a joyful, meaningful life? Think again. Conquering your mental illness is part of living a life you love, and we're going to figure it out together. I'm Chet Roshetko, and this is Drawn. Welcome back, listeners. I am so excited to introduce you to my next guest because this one's a personal favorite of mine. It's the man who created me, who delivered me from my mother's womb. It is my father. And what's actually really interesting is that I know this man. This is my dad. This is the guy that I've gone to for advice, for money, and he's also the guy who changed my poopy diapers when I was a baby. He's the guy who scolded me when I messed up growing up, and now he is the guy who is my guest on my very first podcast. And so I am really excited to introduce you to my father, Chet Roshetko. What's really interesting for you guys is that I don't actually know a lot about his career. I don't know about you guys and your fathers, but he was just my dad, and so as I've talked to him, I've learned so much more about what he's actually done, especially in the field of mental health. And so with that, how cool is this?
Well, it's a great opportunity, Katie. I'm so proud of who you are and where you have gotten to, and this is neat that you have this interest in mental health for both personal and community reasons. And by the way, I don't think I ever scolded you.
Oh, yeah, that's right. I was perfect. What was I saying?
That's correct.
Yeah, we are nothing but honest on this podcast. So yeah, like I said, this is really interesting for you guys, just as much for me, because I'm really asking questions that I don't know the answers to. My dad has had a long-standing career, pre-military, almost 30 years in the military, and now he's been working in the mental health ever since he retired from the military. So with all of that to say, I'm just going to turn it over to my dad and really ask him to set the stage for us and really kind of dive into what exactly you have done in your career in terms of the mental health field.
Okay, so I started in mental health almost accidentally in 1984 when I was hired in my senior year of college at a child adolescent psychiatric hospital in Toledo. And then by chance, I stayed with that job for 18 months as I finished my senior year and then went into the military. So that's where that started. So I was working with kids from 4 to 18 years old in a milieu setting, long-term healthcare or mental health care. And so that was quite an eye-opener. And then I went into the military for 27 and a half years. My first couple of years, there wasn't a lot of mental health. You do a lot of mental health training and be ready for war and dealing with the psychology of war. But then as I got into command, I oversaw mental health clinics for many, many years, probably the last 12 years or so of my career, where I did a lot of work overseeing the mental health clinics and working with the social workers and psychologists and psychiatrists on how to best take care of them. And then, of course, as you know, we had quite a few international conflicts going on since 1991 and dealing with your people, your troops, your airmen. I was in several joint jobs, so I was dealing with all the services. I was in some areas of Germany where I was dealing with people from many different countries, and of course the psychological challenges of being in war and dealing with deployments and dealing with injuries and dealing with families. Tons of mental health experience there. And of course all the PTSD that went along with it, both current and delayed. So including my own short case of PTSD that happened after my career, but because of my career. So anyway,
Wow.
Hopefully that's helpful.
It's very helpful.
And then, of course, when I left the military, I ended up being the chief nurse of a mental health state hospital for the state of Washington. And I did that for over almost 3 years, just short of 3 years. And then I left and did hospice for a short period of time. So there's a lot of mental health dealings or issues regarding hospice, both with the patients and families. And then I went and helped open a brand new mental health hospital in downtown Spokane, Washington, where I currently work.
So if I'm doing the math right, that probably means you have about over 40 years of dealing with mental health and seeing the mental health field change dramatically in that time.
Yes, I would certainly say from the time I started, it's been 40 years. Yes.
Wow. So I guess, in your own words, what is the state of mental health in America right now?
So the state of mental health today is challenging and fragile, and that comes from several things. Most important, that the infrastructure within the United States, within the community, within the family, has fractured to the degree that mental health is almost exclusively a medical issue, when mental health really is a community issue. And we've lost so many of the things that have helped protect and or guide along people with mental health challenges. I always tell the story with my folks back home is when I was growing up in Cleveland, Ohio, there were people with mental illnesses in our neighborhood, and we, the neighborhood, took care of them. I consistently remember my parents just telling us to be nice to them. And I know my friends' parents told the same thing because we were just all nice to those folks who were walking about the neighborhood. We had the Band-Aid man who constantly put mercurochrome all over his body and Band-Aids, and he walked around without a shirt on. But he was nice and polite, and we just took care of him and talked to him. There was Minnie, who was clearly schizophrenic, but she would just be walking around the neighborhood, and we'd be nice to her. And if she went too far away from the home, we would just go knock on the door and tell the family, "Hey, I just saw your mom, but she's this far away." And they would say thank you, and they would go retrieve her and bring her back. And there were several other people. We had a lady in the neighborhood who would actually walk into our home. And Mom said, just be nice to her, redirect her back. And, it was from time to time you'd come in and there she was in your kitchen. And, okay, we'll take care of her. We'll talk to her. And so the neighborhood would take care of these people. And now that would not be acceptable in most neighborhoods where you would have that many people running, or not running out on the streets, but out on the streets without some kind of control. So we have to find a way to have that. The family structure has broken down, the number of single-parent families, the lack of full support at homes, where consistency within a day, within a routine, has gotten away. And so the ability for families and slash neighbors and slash communities to take care of people who have mental illnesses are dramatically decreased. And so people keep thinking the medical system or the government is who's going to take care of these people. And my personal opinion, we really got to find a way for families, communities, churches to play a bigger role in helping guide this. The other challenge with mental health today is that the drugs on the streets are so horrific. Back in the day, if we were to say something like marijuana, people knew what marijuana was. If you said, oh, heroin, you generally knew what heroin was. But now we have these derivatives of marijuana, these derivatives of heroin, these things implanted, mixed in with things like fentanyl. It's just horrific drugs who have long-standing and challenging effects on the body, not just a momentary alteration of your mindset, but long-term impacts on your brain and your thinking. So that's really difficult. And even when people say they take these drugs, we're not even sure what they are. And sometimes it can take weeks or months for us to manifest, or I should say for the drugs to manifest and for us to fully understand what the impact is going to be. So, and then the healthcare system itself is that we are lacking psychiatrists, psychologists, especially child and adolescent psychiatrists and psychologists, at a rate never known before. And we just can't produce enough. For the first time a year ago, first time in the history of America, there's more nurses retiring than there are graduating from school. That's a trend that's going to continue for at least a decade to 15 years. And so we're lacking that support system within the hospitals too. So we are really challenged in healthcare overall, but especially in the mental health field.
And so when you started back in, the 80s, what do you think, society's view of mental health was, and how has it changed over the last 40 years?
Great question. There's been both a much greater acceptance of people with mental health disorders. Back in the day, in the 80s, if you were to say somebody was schizophrenic, that would be a very overwhelming and alarming statement. I think it's much less now, but we haven't gotten to the point of fully accepting. As I've talked to you before, Katie, I got a good friend who helps me with my university classes, and at some point in the class, he asked them, well, what would you do if you came across a paranoid schizophrenic? And you can see their uneasiness of saying, hey, I'd walk the other way, I'd cross the street, I'd kind of protect my kids, I'd walk by them. And eventually somebody will say, I would just be nice to him. And that's when my good friend says, well, you're being nice to one now. And then they become kind of shockingly aware that this gentleman who is giving a lecture in a university is a paranoid schizophrenic who is living a pretty good life now because of his focus on making sure he takes his medications, keep up with his counseling, his spiritual beliefs. And so I think we're more accepting of it, but we're not there yet. The other thing is certain things like depression, post-traumatic stress disorder, even anxiety, much, much more open than we ever were before, which is good and which is bad because there is some copycat behaviors that go on. The more open it is, and truly more people who really have it come out and are more willing to get treatment, it gets more accepted. And at the same time, there's people who rely on it almost as a crutch. And that can become, it becomes melodramatic, and it also becomes very challenging because people want to stay there rather than always heal. And that's a different part of mental health behavior that we have to work with.
So I think that's really interesting, and I definitely want to touch more on that. But because we are really focusing on anxiety and depression, I feel like even in my lifetime, and I'm only 28 years old, I've noticed a change, of how people respond when you start to talk about your feelings, and the negative feelings that you have, the overwhelm, the anxiety, the stress. People seem to be much more willing nowadays to meet you emotionally versus back in the day. I would say, that the old cliches of rub dirt on it, don't talk about it, stop being so dramatic. What do you think has been the biggest turning point, and why people aren't using the whole rub some dirt on it as much when people do start talking about their emotional health?
Well, that's a great question. And again, it's no one thing. It's a combination of things. First of all, there's been a great public awareness effort that's been done that people who are depressed aren't weak. People who have anxiety aren't lesser than you, that they're not that they're just tough, that they're really experiencing this cycle. And people, because of that, people are more willing to say, hey, I'm experiencing something like that. Or they start to recognize it. And that's a whole nother thing, is that people just say, well, that's just the way it is. But now we're realizing that you can label it or name it something, which also then says, hey, maybe I can do something about it. So you have more people willing to talk about it and then get treatment for it. The medications that are out there for anxiety, depression, and other mental health illnesses are better than they've ever been before. Providers are more educated on it. They're more willing to prescribe in that area than send off a referral to a specialist. So all those things come into place. I think people are just admitting it publicly, both publicly, from a somebody who's idolized out there, to all the way down to the common folk. In many churches, something that was never talked about before. It's mentioned on a frequent basis, and there is not a labeling that goes along with that.
So I think this is a really interesting statistic. In 2017 to 2018, 19% of adults experienced a mental illness, which is an increase of 1.5 million people over last year's data set. And that's according to Mental Health America. And it's a really great organization that puts out a lot of research and statistics and stuff. So my question to you, and you've kind of touched on it a little bit, but we can expand on it now. What do you think is contributing to the increase of depression and anxiety, specifically here in America?
Well, before March of last year, I would have talked about it differently than I am right now. So let's go back to the pre-COVID. So before COVID, I think there's several things were playing in it, but probably the greatest thing was the acceptance of it. So more people willing to admit it, more people willing to go and take these assessments, more real people willing to seek help. So maybe the numbers weren't dramatically increasing overall, but the identity of people who had it were increasing. So I think that there's generally a trend ticking upwards because of the infrastructure issues that I mentioned earlier, family, community, economics, the amount of debt that's involved in people's lives. All those things contributed to it. Now we have this whole new chapter post-COVID, and that we've never seen anything like that in our lifetime. And so we might as well throw out all of our history and say this subset, March of 2020 to whatever time in the future we get a grip on this, we're going to have to put that with an asterisk and say this is an outlier, but it's still very serious, and we've got to be aware of it and be able to address it.
Yeah, because another interesting statistic that Mental Health America found is that from January to September 2020, over 300,000 people took the anxiety screen, a 93% increase over the 2019 total number of anxiety screens. And then we actually see that there is a 62% increase over the 2019 total number of depression screens. And screens basically being like people who were, I guess, tested positive, if you want to use that phrase, even though I'm kind of tired of that phrase, as I'm sure as much as you are. And so, 62% more people just in those 9 months of 2020 compared to 2019. What goes through your mind when you hear a number like that?
Well, just the dramatic impact of COVID has had on our communities, and this is probably if we went global, we would probably be very similar to those who could access. So part of it is say, people have more time on their hands. They're kind of, let's go in and do this test. Well, that's going to be some small percentage, but the results of that was a dramatic increase in the number of people who identified with moderate to severe anxiety and depression. And so it's not only more people are taking tests, but more people are identifying, and a statistically larger number. So I know the focus of COVID-19 has been on the physical health and challenges of what's going on with the respiratory system, but I don't think our public health system and our politicians have been fair in fully disclosing the impact that this is having on the mental health and the emotional well-being, as well as the economic component, the relationships have been. And I'm worried that the impact of that is even more severe than the medical component. And we haven't adequately faced it, discussed it, or been fair in our balance on this approach.
So one of the things that you've always said to me growing up is there's no such thing as work-life balance. It's all just life. Amen. And kind of in the same way, I feel like there's no such thing in a lot of ways as physical health, spiritual health, mental health, relationship health. It's really just all health. And there's this symbiotic kind of relationship between all of them together that doesn't seem to be talked about in a holistic kind of a way.
Yeah, I think one of the great failures of our medical system, and I do believe we have one of the greatest medical systems in the history of the world. So I'm not dissing it in total, but we back in the early 1900s we broke public health away from medical health, and then we made mental health almost another separate component of that. And so when I was growing up, public health, medical care, psychiatric care were really separate. They people weren't trained well in all three. They were broken apart. There wasn't a lot of integration. And then during my years in the military, we saw a tremendous effort to integrate that. And now more than ever, we need to. But yes, there is a need for that integration to be greater and clearer and cleaner. And also, as you said, there is no, in my life, in my belief, there is no work-life balance. It's just called life balance. And because we need to do all those things. It's not like you stop living when you go to work or you start living when you come home from work. It is all, part of it. But it's a great opportunity to kind of rebalance all the things we do in life to make sure that we're doing the things that are most important.
So right now, I know you work at a private mental hospital. I'd love to kind of break down exactly what it is you do and kind of what do you see on a daily basis in terms of mental health.
Okay, so I've done many things since that hospital opened. So when you're starting a hospital and you're the sixth person in the door, you're doing everything from moving furniture to, creating policies and getting the marketing out. But right now I've kind of settled into a role where I'm a house supervisor. So Sunday, Monday, and Tuesday night, I am basically the senior person in the hospital on my night shift. I work 7 p.m. to 7:30 a.m. And so I'm overseeing the intake side, which is like what you would know as admissions. I'm overseeing the security. I'm overseeing patient care. And I'm dealing with the numerous employees that are in the building. I also got to make sure that if anything's going wrong in any aspect, whether it's the infrastructure down to employees, that I'm working to address those issues, and then looking out the next few days to make sure we have enough care. So that's what I do. In a sense, I'm a CEO on night shift of the building. So,
okay.
As far as what am I seeing, we are seeing the demand that we expected to see there. There's no shortage of people trying to get in for healthcare. No shortage of referrals. There is a tremendous demand for. We're an acute care hospital, so our goal is to see people in 8 to 12 days. But unfortunately, it's not enough. We're a 100-bed facility, and in my opinion, we need more than 100 beds where we are to do what we want to do. And that's just to take care of the acute psychiatric hospital. But then there's moderate psychiatric inpatient care, which doesn't really exist really in our area. And then there's long-term or chronic, where the state hospitals come into play. So I think that we need to really have a deep look into healthcare and see how we're going to be able to accommodate that. Because when you're dealing with acute care patients, but you got a bunch of moderate or chronic mixed into that group, you can't provide the proper services for those people, because it doesn't work for all three. I mean, you don't, just like any other part of healthcare, you don't go see some kind of specialist if you got a different problem. You've got to see a specialist in that area. So the other thing is the lack of outpatient treatment, both basic outpatient treatment and intensive outpatient treatment. And that's an area we need to work in. And of course, Katie, then it goes back to what I talked about earlier, is that we've got to make it a community issue, and we've got to make it a family issue. We got to make it a neighborhood issue. We've got to make it a church and social service issue, in the sense that all of us need to be more involved in understanding mental health and playing a role in taking care of individuals and in small groups.
And so how do you help somebody heal their minds, heal their mental health? Because it's not like you come into a hospital with a broken bone and they can fix it, set it, put it in a cast, and let the body kind of do its work. The mind is such a fragile thing, and it's so complex. We're learning more about the brain now than we ever have, and yet there's still so much more that we need to do. So how do you go about helping people heal their minds?
Slow and steady wins race. Your example of the broken bone is great. You can see a picture of the broken bone, you put a cast on it, you then get a new picture 6 weeks later, and you see that it's healed, and you go, okay, go on back to do what you're doing. With mental health, you measure it in certainly in inches, if not millimeters, and depending on the disease you have, the severity, illness, it's dealt with that way. We, in America in particular, we love the quick fix, fix it and get it out. Give me the pill, get it out. And for the most part, none of the mental illnesses will be healed with a singular event, like a 1 day, an 8 day stay in the hospital, or here we'll change your medicine to Abilify or whatever, take another Ativan, fix this. Because the majority of mental illnesses is behavior related and experience related. So, as I say many, many times, nobody that I have ever met woke up this morning and say, I'd like to be schizophrenic by 10 a.m., or I'd like to be in major depression at 2, or I'd like to become antisocial at 4. It is long-term developed behavior that is going to take a while to address. Get them on the right meds and get it into therapeutic range. Work through the horrific background of experience that they've had to properly address the issue, because it's scary to go back and relive those things, but then to clearly identify the triggers, and then to build up adequate coping mechanisms, and then build a lifestyle that will avoid the triggers and enhance the coping mechanisms while you're staying on your meds and while going through counseling. So those are huge things. And then, of course, there needs to be the willingness of the patient to want to get better. Many of these patients have been their potential has been so diluted down by their disease, they no longer have significant ambition or hope. And so they just are caught up in, I'll get through today, get through the next meal, get back to sleep. And you've got to rebuild within them the possibility of a future that they can grasp and hold and thrive on, even with their condition. And that is a real challenging task, because so many of them have gone into survival mode for so long that they really have lost that belief. The other thing is, because of their disease, many of them tremendously lack good social skills. So people are uncomfortable around them. They're uncomfortable around others. And so we've got to be thinking long term on everything, on patients who have moderate to severe mental health. And again, that's why the whole community has to be part of helping these people.
So many of you guys know that I have my own personal relationship with mental health. I was diagnosed with anxiety and depression in 2018, though I have a feeling that I'd been experiencing a lot of that before then. Kind of coming out of college, being thrust into the real world was a very, a lowercase t traumatic event for me. And I don't say capital T traumas and lowercase t traumas in a way to rank my trauma compared to somebody else's, but really it's for my own sake to kind of understand the big traumas in my life compared to the little traumas, and really make sure that I'm putting it into a healthy perspective of my own experiences. But through all of that, I've gone through therapy. I've been in therapy for about 2.5 years now. And I can honestly say that it's the best thing that's happened to me, but it was a really long journey. I mean, I don't think I had a quote unquote breakthrough for maybe 1.5 years. And that's on top of trying medications, that's on top of job changes, that's on top of learning external coping mechanisms, from trying to do meditation to really starting to pour into my faith a lot more, a lot of prayer of God, please take this away from me, but I still can't get out of bed. So there was a lot going on, but the long-term thing is what I think a lot of people don't really realize, because we are a microwave society where we want to come in, we want to fix the problem as quickly as possible and move on to the next thing. And I'm that way too. I am a checklist person. I want to do things one right after the other, and I don't like to spend a lot of time doing one particular thing. So with that in mind, I just want you guys to know that both my dad has said it and myself, we've experienced mental health in a way that kind of also, I believe, gives us a unique perspective to help people. And I want to turn it over to you, because you have mentioned dealing with PTSD, and you've mentioned, and I know, from growing up with you, obviously, that, there's times and seasons in your life when there was a lot of stress. And I remember, the aloofness that there was as you were dealing with a lot of things at work. But now you're working directly in the mental health field. And so if you wouldn't mind sharing what you're comfortable with about what you've been through mental health wise, and then how you've been able to use that to help people and connect with the patients that you have now.
Yeah, I mean, I had a childhood experience, probably seventh and eighth grade, where I went through something what we back at least back in the day called school phobia. Now this is self-diagnosed after understanding what I went through and then growing up and dealing with it. But a lot of performance anxiety, thinking that I had to achieve so that I could prove to whoever, friends, family, school, that I was somebody based on some level of accomplishment. Everything from my religious experience, where there was a lot of guilt-driven things at that time. I've learned a different spiritual course since, and so there was a lot of that. And then there was a particular incident or two that was pretty traumatic. And when I went into what clearly was a depression and a sadness and bad thoughts, and but really my parents were there for me, that they didn't really know what to do exactly, but they just loved on me, and they just were with me as I went through it. And it really took probably 2 years to get out of the most acute phase of it, and then it took really probably another 10 or 12 not to be so anxiety and performance driven, to the point where it was impacting my life. Now, as Katie would attest, performance and achievement always was kind of lingering there. And part of it is you get the taste of success, and you're thriving for it because it's fun and it's enjoyable and the whole bit. But another part of it is, will I be worthy of myself if I don't? So, a lot of people who have had some levels of success are familiar with that. But the PTSD for me is that I was, as a commander in the military, having sending many, many people to war, seeing some of them not come home, seeing some of the devastation that they went through. Through all that, through my entire career, I was a 4-time commander, a chief nurse twice. I dealt with it well, and especially when I was over in Germany, we would have 5 to 7 plane loads of hurt coalition forces come in every week. Tremendous trauma, polytrauma as we called it, lots of mental health illnesses. But I dealt with it, and I did fine. But it wasn't until I retired, and I was just at the movies one day, and a preview for a war movie came on, and I really lost it. I knew exactly what was happening. My breath increased. I was breathing rapidly. I was uncomfortable. I was twisting in my chair. I had a fearful thing. And I knew right away. I said, oh my gosh, I'm experiencing PTSD. I can't believe it, years after I left. And Carla, my wife, realized something was wrong. And she said, what's wrong? I said, I'm going through PTSD right now. And she goes, what do you want to do? And I said, I'm just going to close my eyes, and I think I'll be okay. And I was able to breathe my way through it, and the preview was over, and I watched a movie, and I went home. But over the next few months, things startled me. I wouldn't call it a flashback, but I would have an experience, especially things like TV or a loud noise, and I would feel the heart rate going. And I knew what to do, so I wasn't like I was in super needed treatment. I had worked with people for so long, so I was walking through it, and I knew one of two things would happen. It was either going to get worse and I needed treatment, or I was going to be able to move towards a control of it, and control in a balanced way. But I did, and it took me about 18 months, 2 years to get it where I was getting less and less affected. And finally, I thought, hey, I'm good enough now. And I said to Carl, I said, hey, I want to watch this movie, but I want you to be there. And she goes, are you sure you're ready? And I said, yeah. And so I was able to, and really, I knew at that point that I had gotten past the acuteness. Now, in my particular case, my life wasn't dramatically affected. I was still going to work and the whole bit. But it was a small experience that had really kind of came out of nowhere. I mean, to me, the shocking thing, it was years later that it happened, and I was already out of the military. But that's analogous to what many people experience. It's post-traumatic. It's afterwards. Something triggers, especially childhood experiences. For some people, it triggers as an adult. And so that would be mine. And if mine was minor, and I would certainly say it was, I can't even imagine how totally uncomfortable and scary it would be to go through post-traumatic stress over major or cumulative traumatic experiences. So, Kate, I teach one of my courses at one of the universities is on healthcare. I teach another one on dealing with trauma-informed care. And the people who attend my classes, those who sign up, tend to be people with having had those experiences. And so, well, it certainly changes the classroom setting from a pure learning to have people exposed how many have been through such traumatic things. And it's shocking how well people do despite their experiences. So not sure if I answered your question, but hopefully that's a helpful reflection.
Yeah, no, it really is. And I think a follow-up is just like, what is the benefit in storytelling and sharing experiences?
Yeah, well, it's tremendously helpful. I mean, the caveat always is be careful that you don't step outside your ability to help. You never want to make things worse. You never want to push when the door isn't open. So I think just to turn this open and say, hey, everyone talk about all your experiences to everyone, and everyone ask everyone about their issues and demand details. I think we got to be careful with that. There is a fine line between, there's a definite line between medical counseling and storytelling that helps you build relationships and get support amongst friends and family and spouses and the whole bit. So the value of storytelling is that you don't have to be alone with your experience. You can share it to the degree that you're comfortable, and you'll be identified one way or the other of whether not always, it doesn't always validate exactly what you're feeling, but it will allow you to put those feelings in a perspective. And without dissing anyone, but there are people who will get way overreact to some minor issues, and you can use the word drama queen or something. And if you just validate their feelings all the time, they'll just remain in a drama queen world or king world. And yet what you can also do at that time is say, well, I see that you're struggling with that, but do you know the majority of people go through that? So it's more normal than it is abnormal. And I bet you we could come up with ways to deal with that, as opposed to, turning your life upside down over it. So I think there's real value in us coming along and helping people put that into a balanced perspective. At the same time, when you're reliving that, the more you relive it, in general, in that process, it becomes less of a trigger, and you develop proper coping mechanisms for the issue. Now, I got to be careful here, because that's not always the experience. There's some things you got to be very careful about going back through or keeping yourself exposed to. There's some things you don't want to do that at all. But storytelling is a very valuable way. And if you're the recipient of the story, you're hearing it, what I would just encourage you to do is do that very active listening. Put everything else aside. Put your phone aside. Put your time aside. Put your pets aside. And sit there. You put your elbows on your knees, lean towards them, and just say, hey, I am here. I am here to listen to you. Don't promise to help them. Don't promise everything's going to be okay. But listen to them and have them share and be there for them in that moment. And then decide what you can or can't do to help them. Don't try to overfix something. Don't try to poo-poo something that's serious. And if you don't know, just say, I don't really know how to help you, but thank you for sharing. I hope that was helpful. What can I do for you right now? So allow them to build that relationship with you. So many people with mental health illness have no good relationships. There are so many times you get these people who are very sad, depressed, suicidal, and you ask them, what is your reason for living? And they have no reason for living. Who is somebody who's important to you? And they don't have a name. They have just been discarded in their belief from society. And that's just, those are the saddest moments in mental health, is when there's a complete sense of hopelessness.
So what do you think is the biggest determiner in somebody who gets better compared to somebody who doesn't?
Again, I think it's threefold. It's the proper medications in the right therapeutic range where they continue to take them. So have to understand that there's three parts. What's the right medication? What's the therapeutic range? And does the patient continue to take them as prescribed with the adequate follow-up to make sure that the dosage remains the same? Now, the vast majority of mental health patients will need some kind of medication. At the same time, I'm not pushing pills here. The counseling that goes along with adequately taking the time to understand the triggers and to develop the proper coping mechanisms, and that really is a long term. And then a personal sense of relationship with the community, a purpose for their life, and what I think is the strongest thing is a spiritual foundation that is consistent, that has values, and that they can rely on those most difficult days.
So I just want to make sure we understand medication, community, and a spiritual foundation.
With and proper counseling too. So
counseling.
Medication, proper professional counseling to help identify triggers and coping mechanisms, and then the community relationship, which is often the spiritual relationship. So that combination of things tends to lend to the most successful outcomes from people who are dealing with everything from minor to severe mental illness.
So one of the phrases that we've all used before is the will to live. How important is that?
Well, it's huge, and the majority of people who and I thank you for asking this, because this is a misnomer and we have to understand it. And I think everybody who hears this, if you understand this, you go, oh. 99.9% of people who are talking about committing suicide are not really interested in ending their life. They're interested in ending the pain that is causing them to be so terribly disenchanted with life and so in such distress. So what I try to do is work with the patients to identify what is the painful part of their life. It could be the voices in their head. It could be the sadness over the loss of family members. They could have been involved in a crime where they were the predator and they did something really wrong and there's a tremendous sense of guilt. It could be loneliness. It could be physical pain from a disease process that's causing them to have the mental health pain and saying it's not worth living. So they're there. Thus, this is the way I approach it with my patients. Is I talk about something, here's a medical term coming at you, cognitive constriction. And you think of the word cognitive, that's thinking, it's restricted thinking. Here's the term we use all the time in our lives, is tunnel vision. It's basically tunnel vision. And so I talk to my patients and I say, I want you to know that I'm there with you, but you're in a cave. And I'm in the cave with you. I'm right on the outskirts of the cave. And when I look outside the cave, I see all these possibilities for your life. But for you, you're in the cave, or you're very deep in the cave, and all you can see is the little light at the opening. And every time you go back further and further in the cave, the opening gets less and less and less. And so you see less opportunities. And you've gotten to the point where the only opportunity you can see to get away from the pain is to end your life. Well, I understand that. Study after study has proven that what you're experiencing is real. We've talked with tens of thousands of patients. What you're experiencing is real. At the same time, you have to understand that what I know by these studies, what I know by my experience, is that you don't have to stay there. That I can see all the options, but I know you can't right now. So what I'm going to do is I'm going to be there with you. And all I'm going to ask you to do is we're going to take a small step forward. Every time you take a small step forward, you're going to see more and more possibilities. And pretty soon, as they start progressing towards the entrance of the cave again, the thought of suicide decreases because they're starting to see more options. They're starting to see of different ways to get rid of the pain. Did you bring them right up to the edge, and voila, there's the whole horizon again, and all those possibilities are there. So I say that the thing we can do most for people who are suicidal is to give them hope. And to give them hope is by saying there's lots of options that I can see, even though you can't see them right now. I'll be there with you, but let's just keep taking a step forward.
So our time is getting short, so I want to make sure that we respect everyone's time who are listening to this, but obviously this will not be our last conversation. So let's just go ahead and kind of wrap it up with your last thoughts on what is America doing right in terms of treating anxiety and depression, and where do we need to improve?
Well, clearly the thing we're doing right, and I congratulate the health system, the medical system, the communities, the social services who have moved depression and anxiety away from some thought of that you're weak to being a mainstay of many people's lives. And thus we're able to talk about it openly, comfortably, with lots and lots of less stigma around it. So congratulations to everyone over the last 30 to 40 years who have made that possibility. We can't thank you enough. What we need to do more of, we need better, stronger family structures. I know people don't like to hear it, but fathers, you got to stay in the home. You got to get in the home. You got to be a role model. You got to healthy, strong marriages are a better way to go than our current thing. We need the communities, the neighborhoods to reach out to help others. We need more people to go into healthcare, into nursing, into medicine, so that they can provide that service. We need to get a better handle on the whole insurance challenge and access to medications. And so really the list goes on. I would say if we address those things right there, it would be a fantastic leap forward.
Well, I can't thank you enough for being on my show, Daddy-O.
Hey, daughter-O, you're welcome.
This has been eye-opening for me, as I know it has been for our listeners. So is there any other final thoughts that you want to give to our listeners? Anything else that I didn't ask you that you think is important to add?
Well, from a spiritual aspect, Katie, as you know, I became a Christian at 31 years old. It dramatically improved and changed my life from just a viewpoint. I think that Jesus Christ is the answer for everyone, as God said it was. And I wish I could can it and just hand it out, and everyone would take it and do it. But that's not the way that works. I would just ask for people to consider what the Bible says about truth and about life and about the fact that once we have Jesus, we have everything. So the singular most important thing in my life has been accepting him as my Lord and Savior. At the same time, for those of you who aren't believers, don't lose hope by any means. There's many, many things that we can do to help you decrease your triggers and increase your coping mechanisms. So, Kate, thank you. It's an honor. Love you. And I'm so proud of who you are and what you're doing.
Thank you, Dad.
All right.
Thank you for listening to the Drawn Podcast, empowering women battling anxiety, depression, and other mental illnesses, where I believe we've been drawn together to create a life we love. You can find more amazing content at my website, KatieRoshetko.com, or follow me on Instagram at The Drawn Collection.